sat nav, a way of seeing where you are in the brain on the MRI scan. Or sometimes we use the...
Sorry, explain that. Is there actually a voice telling you to turn left?
No.
No, sorry.
No, there isn't. It is we look at it on the scan, and it tells us where the end of our probe is. So it's more like when you look on a map and you constantly refresh it, and it tells you where you are on the map.
Oh, like the blue dot moving along.
Correct.
So, so when you're actually operating...
Yeah.
You've got your tools and going into the actual thing, but your eyes are looking at a screen somewhere else. So what? I mean, how tricky is that to do?
You don't always look at one or the other. You're operating by looking at the brain, and then every now and then you look up to look at the map. And then come back down again.
Where is this physically positioned? You've got those funny sort of super lenses on.
Yeah, this is a screen system that sits on the side of the patient, or at the end of the patient.
So it's attached to their head?
Yeah, there is a bit that's attached to the head that gives you the reference to tell, so that the sat-nav system has got cameras and is looking at the bits that are attached to the head. A bit like the satellites you've got over in the sky above you. You've got these cameras that are looking. And what we do is we have a fixed point that the camera can always see, and we tell it various locations within the head. We say, this is here, this is here, this is here, and it knows where those locations are relative to the fixed point that's attached to the head. We then tell it where those exact same fixed points are on the scan, and it can then use its 3D trigonometry to tell you where you are.
So you say, it's
basically the way that GPS works.
But this is a whole new area I didn't expect to be talking about. But so you've got a machine that you have to program. Did it take ages to program, or is it?
No, not necessarily. It works from the scanner. The patient's already got a scan, and it works from it.
Okay, the information feeds into the. What is it? A laptop or an iPad sort of thing, or is it?
Yes, it's a full stand thing. So it's a computer with a screen, but it's probably a laptop power nowadays. And it's attached to the cameras and the screen that you can look at. So how big are these cameras? Oh, not very big. No. So the whole thing is, the camera setup is probably about the size of a sound bar, a small sound bar. So that's on an arm that's looking at the patient. And so where is that positioned? Next to the patient. I'll email you a picture of what it looks like. Oh yeah, could you? Because I'm struggling, if I'm honest. It's just the tech of it, because I'm imagining that you've got those. What do you call those lenses that you wear? The optics that you wear? Those are loops. Loops. L-O-U-P-E-S. Loops. Okay, and so I'm just thinking, whatever you're looking at, you need to be able to see the screen as well. Do you just wear that on one eye or both eyes? No, I wear them on both eyes, but I can look over them. Okay. So the loops are just they're designed so that when I'm standing in my operating position, the loops come into my eye angle, and I can look down through them. But then if I look up with my eyes, I can look over them, because the rest of the lens is a normal lens. So that's super varifocals or bifocals. Yeah, yeah. So what percentage? How magnified are the loops? The ones I have are 2.5. So you can get 3.5 and then 4.5 in fact, I think. Oops. Okay. Sorry. Okay, I've diverted you onto a technical matter. Sorry, you were telling me. So yes, tell me what. You told me what you trace it via the sat nav. So when you're actually looking for something, you can do it by anatomy. You can do it by sat nav. You can do it by ultrasound. So we use the ultrasound a lot in the operation.
So is that live ultrasound or just a scan from an ultrasound?
No, live. So I have an ultrasound machine, which I can just plug on and put onto the brain itself, and then run it over the surface of the brain and look to see what's going on inside.
And do you do that because you don't know where you're looking? Because normally you would know what you're doing before you started. Is this for confirmation or just to...
But it's because sometimes the tumours can look very similar, like we talked about.
Okay.
And so if we want to follow it, we can follow it live on there. We can just look in.
Right.
And the other thing we can do is we can use it to tell us, as we're getting to those edges, when things are starting to get difficult to recognise, is this tumour, is it not tumour, then we can use that to help us, guide us on those.
Okay. So
that can be really helpful when you're on the edges of the tumour and you're thinking, is that tumour that's left there or not? It may look the same, but it may have a completely different ultrasound appearance.
I'm sorry, when you talk about that you can't tell, it's just sometimes when you have meat, they're cutting the fat off, you think, is that meat or does the colour changes? They get so close at the edge, and I'm sorry, that's a poor analogy, but that's all I'm thinking.
No, but it doesn't always, unfortunately, it doesn't always do that in this case. Sometimes it's not as obvious as meat and fat.
No, that's what I'm saying. Sometimes my children cut off something that they think is fat, and I say, no, that's meat. That's what I'm. There is that vague bit in between where you can't tell.
Yeah.
We need an ultrasound for dinner.
You need, yeah. I mean, it seems really odd that you can't tell the difference, but it's as you get closer to the edge, and as tumours get more and more like normal brain tissue, it becomes very important to look at that.
If it's a malignant tumour, so one that divides, is it really the case that you need to get every single cell and every single part of it, because from one part it can rebuild, or basically, what are the risks of leaving some?
Depending on malignancy levels and cause, there are different risks. So sometimes we will deliberately leave some tumour behind if the risks of damage to the brain are too high.
Yeah.
And if the risk of leaving some are relatively low. So if this is a benign tumour that's very slow growing, well, if we debulk it a lot, then it may take many years for that tumour to grow back. But by leaving the bits on the edge, we may be minimising the damage we do to the patient, or we may say that's fine because we're going to come back and do chemotherapy or radiotherapy to the remnants.
From just a physics point of view, though, can any part of the tumour that's left grow? Can they all self-replicate and expand?
It can do, yeah. Yeah, very occasionally, with a certain type of benign tumour, you can damage it enough that you damage the blood supply, even to the remnants, and so it doesn't come back.
Right.
But that's relatively unusual.
So if you leave two parts in two separate areas, you can assume that both parts will actually grow at maybe different rates, but they will.
Yeah, you'd be worried that they'll both be back, so you'll have to keep an eye on them, yeah.
Yeah, okay. Sorry, carry on.
Where were we at?
I keep interrupting, I'm sorry. All these things at a basic level, I mean, I could Google all of this, but as you're talking in your language, I want to clarify in your language, if you know what I mean.
But yeah, I mean, it's not really us writing a book if we're going to just copy it off Google. Really.
No, that's not fine. No, I mean, a lot of it is just background, but it's background that your words are more entertaining than, or more, interesting.
Yeah, more me.
Than the machine, so.
Yeah. So we're talking about, so taking the tumour, yeah. So for those tumours where we're worried about the risks of taking them out, or where we're worried that, where we think actually